So good morning, everyone. I want to thank you for taking the time to join us. Again, I'm County Commissioner Josh Parsons. Welcome to our virtual Lancaster County Joining Forces Community Forum. Appreciate everyone taking the time to join us for this again. And I want to thank the entire team for putting this together, especially the Penn Medicine LGH team, who have been busy with many things over the last year, but have continued to do the work for Joining Forces as well. So we appreciate it. Just a note, all participants are in listen mode, so we encourage you to use the chat box at any point throughout today's session. Moderators will be monitoring the chat box and will assist you trying to answer your questions either live today during the presentation or getting the information you need afterwards. So, as you all know, the past year during the pandemic has been a very challenging time for all of us, every person in Lancaster County, especially challenging for individuals, families, and service providers on the front lines of the overdose epidemic. Similar to many communities throughout the United States, Lancaster County has experienced a significant increase in overdose deaths during 2020, which is troubling and disappointing, especially given all the work that this group has done and the entire community has done in lowering those overdose deaths during the previous year. So we want to refocus and get back to work. Joining Forces, as you all know, continually aims to be a data-driven group. We typically do, as we typically do at our forums, we'll begin today with a data snapshot of Lancaster County, which will include data around overdose deaths and risky prescribing rates. After that, we'll learn about the basics of harm reduction with an overview provided by Carmela DeSoma at the Lancaster Harm Reduction Project. Then we'll learn about overdose fatality review teams and how they're being used as a tool across the United States to reduce overdose fatalities. Throughout the morning, we will invite you to share how local needs have shifted and ask you to help us identify strategies that we can all implement now to reduce overdose deaths. We will have time for questions and answers after each presentation this morning. Please put any of your questions in the chat box at any time. Moderators, as I said, will be monitoring the chat box. If there are questions that we're not able to get to this morning, our moderators will work with you to get your questions answered after the event. So thank you once again for joining us and taking the time to do this important work. And at this time, I'd like to welcome Brenda Boucher to provide our very important data update. So Brenda, I will toss it over to you.
All right, thank you. So Christina, we can go to the overview of the data presentation slide. And we're going to talk today about the trends that we've been seeing over the past few years, going back 10 years in Lancaster County and in the state overall. We'll talk about the increases and decreases we've seen over time, and then some of the demographic trends that we see in fatal and non-fatal overdoses, and then also some of the changes in the substances that have been involved in fatal overdoses. So as we go through, I'll encourage you to think about how this data applies to the work that you do. All right, minor glitch with the slides. Give us a moment. Let me look at what I have first up here. So as many of you know, we had a large increase in overdoses trending upward over time from about 2014, 2015 was when the increase first started, and then we had a peak in 2017. So since then, we had a very significant decrease in 2018. So Lancaster County overall had almost a 40% reduction in overdose deaths. And then it stabilized. And then in 2020, we saw an increase again. So 2020 had the highest number of overdose deaths that we've had since 2017. So some of the information, perfect. We can go to the next one. There we go. All right. It's much better to see this than to just hear me describe it. So 2017 is that peak that you heard me just mention. Then we had the decrease in 2018, stable 2019, and then an increase again in 2020. Our 2020 data is final. Some of the data that I present is not going to be complete for 2020, but our county coroner's office does a very good job of keeping up with those reports. So 146 is our total for 2020. In 2021 to date, that's probably deaths reported around like through the end of March, I would say, is what the reports are coming in now. So about the first quarter of 2021, we've had 32 overdose deaths so far. And we can go to the next one and look at what the difference is between Lancaster County and Pennsylvania. So this is overall the overdose deaths in general in Pennsylvania going back to 2012. So you can see a similar pattern. In the state overall, we also had the highest number of deaths in 2017, decrease in 2018, stable 2019, and then an increase in 2020. But if you want to go to the next slide, this is going to look at our rate of increase and decrease in Lancaster County and then in Pennsylvania. So the solid color bars are Lancaster, and the kind of speckled bars are the state overall. A red bar is an increase, and a green bar below the axis there is a decrease in deaths from year to year. So when we're looking at this, we can see those kind of substantial increases that we had in Lancaster County from 2014 up to 2017, and then the decreases and the increase again going from 2019 to 2020. But the other thing that you notice about this slide is that our variation in Lancaster has been more extreme. So we had higher increases and higher or lower decreases from year to year compared to the state of Pennsylvania. So same trend, just a little bit less of a change in the state overall compared to the county. And then we can go to the next one and we'll look a little bit more in detail at quarter over quarter. So this is just overdose deaths in Lancaster for each quarter, so we can see a little bit more of what's happening over time. The pattern, again, is pretty clear here. So we're starting at 2017 in this graph and coming up to the most current data that we have. And you can see that in 2017, we had those higher numbers each quarter, the decrease, 2018, 2019, and then in 2020, we had some higher numbers again. For the first quarter of 2020, it's really, or 2021, it's really too early to tell what the trend will be this year, but we had 32 deaths, like I mentioned, estimated for the first quarter of 2021, which is, around the same place that we have been over the past year. Okay, and the next one. Now we're going to look at just two things that we have to understand a little bit about what's happening with non-fatal overdoses. So this graph shows emergency department visits for opioid overdoses in the county and in the state of Pennsylvania. So the pink line or the lower line is Lancaster, and then the red line, the higher line, is Pennsylvania. So overall, going back to 2016, the county in general has been a little bit below the state as far as ED visits per capita, so controlling for our population, than the state overall. But this has been pretty flat. So if you think about comparing this to that graph that we saw with the increase in 2017, decrease 2018, 2019, and then an increase again in 2020, you don't really see that so much here. And then if you look towards the right side of the screen, the most recent data that we do have this decrease in emergency department visits from the second quarter of 2020 through the present. So I think that that's an interesting thing to think about in the work that you do. when we're still seeing a similar number of deaths over the past few quarters, why are we seeing fewer emergency department visits? Is that because people are alone and there's nobody to call emergency services? Are people reluctant? Is it the substances people are using that are more fatal and gives people less of an opportunity to seek emergency care? So it's something to think about. What is happening in the world that kind of explains this data? And then the next slide is going to be naloxone use. So I have mentioned this before, if you have seen a data presentation from me, that the data on naloxone use from emergency services is very good. It's solid and very complete. The data that comes from law enforcement and reports from bystanders, Good Samaritans who have used naloxone in an overdose emergency is not as complete. It's not required. We just rely on what people report to us. So it's likely underreported, particularly from the public. So this chart also goes back to 2017. I would say if you focus on, so the dark purple bar, the bottom bar is the emergency services use of naloxone. And that's something that I look at to get a sense of non-fatal overdoses, right? Because in a lot of these cases, naloxone does save somebody's life. And this is just a way to see how often emergency services is having to use naloxone to respond to an overdose. So particularly if you look at 2019, 2020, you can see here a little bit, if you look quarter over quarter, like comparing quarter one of 2019 to quarter one of 2020, that each quarter EMS was using naloxone more frequently. So so it wasn't just that people weren't getting emergency services. It looks like there were more overdoses happening as well. And then the next few slides are the demographic information about overdoses going back to 2017. And as you look at this, I think what we would encourage you to do is think about the people who are most at risk from dying of overdose. And does this population look like the population that you're serving? If you are in this field of trying to help prevent overdose or reduce harm from substance use, does this match the people that you're serving? And are there communities that you need to do more outreach to? So every year going back to 2017, males have been more at risk for overdose deaths than females. This is the same in 2020. That said, you can tell that since 2018, the percentage of deaths among females has been increasing and the percentage among males has been decreasing a little bit. On the next slide, we have the demographics by race. This data only goes back to 2018 because I don't have it as complete for 2017, but here we have the population or the percentage of the deaths that have occurred in each racial group. And then I've noted in italics there how much that race makes up of the actual overall population of Lancaster County, just so you can get a sense. So again here, most of the deaths are in white people. That is also the largest racial group we have in Lancaster County overall. But white people make up 74% of the overdose deaths and 89% of the population overall. So that means that some of the other racial groups make up a disproportionate amount of the overdose deaths. And one of the things that was particularly striking when we look at 2020 is that the Black community makes up 4% of our population, but 9% of the overdoses in 2020, which was a pretty significant increase over what it had been in past years. Okay, and the next slide. This shows overdose deaths by age group. The age groups that are most at risk for overdose are 25 to 44. However, in 2020, if you look at the 45 to 54 and 55 to 64 age groups, they accounted for a lower percentage of the deaths in most cases, particularly that 55 to 64 age group, in years before 2020. So in 2020, there was an increase in the percentage of deaths that occurred in those age groups. So that's another thing to just compare to your experience and think about what you have seen happening in the community with those age groups in particular. Okay, and then I think the last two that I have are the substances. So this is not the whole year for 2020, but I did just want to show you the trends in the substances that are involved in fatal overdoses. So as we've talked about before, fentanyl has been increasing in involvement in overdose deaths. So we are up to, more than 80% of fatal overdoses involve fentanyl. They may involve other substances as well, but fentanyl is there. Heroin has been decreasing in the percentage of deaths that it has been involved with. If you look at prescription opioids on this one, that had been decreasing 2016 to 2019. Again, we don't have all of 2020 yet, but it still looks like prescription opioids are going to be present in more overdoses than they had been in some of the past years, at least in 2019. And then the next slide will also look at a couple of different substances. One thing that we've heard from partners is that they have observed that stimulants are becoming more of an issue. So on this slide, you can see that amphetamines have been present in an increasing proportion of overdose deaths. So that is kind of real world experience that is starting to show up in the data as well. And that is it for my data update for today.
Thanks, Brenda. I personally always enjoy hearing about your data presentations. So at this point, we would like to invite you to ask any questions in the chat box about the data. And I'm going to see if I can walk and chew bubblegum at the same time here and do a little tech wizardry and share my screen, because we'd like a little bit of feedback from you as well. So we would invite you to join us on this poll everywhere while you're composing your questions in the chat box. And you can either participate in this poll online if you're on a computer, and you can copy and paste that URL, which is pollev.com/joining forces, not joining forces, just JForces 891. Or if you'd prefer to use your cell phone, you can text. Message and data rates do apply, and we would, if you're choosing that method, you would need to start a brand new text message. In the to section who you're sending that message to, you're typing the number 37607, and then in the body of the message, you're typing JForces 891. You'll send that, you'll get an automated message back that will let you know that you're joining this poll, and then you'll be able to share your answer. So our first poll question is, what factors do you see in the individuals and families that you serve that you believe may have contributed to the increase in overdose deaths in 2020? And if you're not a poll everywhere kind of gal or guy or person, we would invite you to kind of share some thoughts in the chat as well. So we're looking for what factors that you saw in individuals and families that you serve that may have contributed to the increase in overdose deaths in 2020. Again, we invite you to do that via poll everywhere, or if you're more comfortable using the chat feature in BlueJeans, we would like you to do that today. So Brenda, while we are waiting for folks to kind of share that feedback with us, we have a couple of questions. I'm not necessarily going to get to them in order, but Peter's asking if the data is available somewhere. Peter, the slides for today's event will be on the Joining Forces website. So if you go to lancasterjoiningforces.org and then you navigate to the community partnership page and scroll down, there will be a button towards the bottom of the page where you can click on forums, and then following through from there, you'll find these slides, some information from our community partners, and some upcoming local events that are also happening. So I will share that with you. And then Tracy is asking if we have the ED data broken down by health system. Brenda, what would you say to that?
Yeah, so one other thing actually I want to say about where the data is available also, if you are a data person like me who would like to explore this between Joining Forces meetings, I do have two recommendations for you. One is overdosefreepa.org is where you can see data on all the counties in Pennsylvania, substances, total numbers of deaths, that kind of thing, and demographics as well. And then the other one is if you Google search for PDMP Interactive Data Report, that's the Prescription Drug Monitoring Program for the state of Pennsylvania, there are many, many data points there as well that are helpful. So, two recommendations. The emergency department data is compiled by the Department of Health and reported for the county as rates overall. So I don't have individual emergency departments by health system.
Okay, thank you, Brenda. So I'm seeing some kind of common themes in the answers. I'm seeing, isolation, mental health. Certainly, folks are referencing the pandemic, COVID-19, and increased stress and anxiety, not being able to have face-to-face services and those kinds of things. Folks are also kind of referencing some of the money that was given in terms of stimulus may have prevented some folks from seeking help maybe as quickly or as soon as they may have. This is excellent feedback. Please keep it coming. We do have a couple more questions for you in our poll everywhere. So I'm going to head on to the next one. This will keep accepting your responses. So 2020 overdose data showed the largest increase in adults ages 45 to 54 and 55 to 64. So if you are already reaching this population, how are you doing that? And if you're not yet working with this population, what could you do? What would you try?
I just want to note, Alice had made a comment about the increase in reports of bystanders using naloxone, and it's something to mention that I think I will be really interested in hearing from Melinda later on about what her thoughts are about increased bystander use of naloxone. I think as far as my data goes, that increase is probably due to increased reporting. And again, particularly from the Harm Reduction Project, they have done a really good job at getting reports that are anonymous, but give us a lot of information about how often the naloxone that we're giving out is being used. And so we have really seen an increase in reports. I'm not sure if it is an actual increase in, more bystanders using naloxone. I hope so, but not sure.
There's always a tricky thing for us to really understand what that means. Something we talk about a lot, so we would be open to any other ideas or thoughts around that. So again, if you're choosing to participate in the poll, you could do that through the website or using your smartphone. If you've already logged into the poll everywhere, you don't need to log in again. You can simply just submit your answer. And so So not as robust of a response yet on this question. Maybe you haven't finished that first cup of coffee yet today, but we are starting to get some responses in. So target marketing is a great option, particularly if you have the funding to be able to do that. Mental health first aid training to bring awareness to people and better prepared to notice change and support and reduce stigma. I think that's a great idea. If you are aware of any of those trainings that are coming up that folks could register for, I'd invite you to share that information in the chat, and then we can also disseminate that after today's event. Okay. So in the interest of time, I would welcome you to please keep sharing your feedback with us. It is super, super helpful. But as I sit here and kind of simmer on some of this data and I start to try to make sense of it in my own mind, and I think that Brenda teed it up nicely for the harm reduction project. Harm reduction certainly is an evidence-based, effective tool that we have at our fingertips. I think about how a lot of the work that's done is really about providing a non-judgmental, safe space for individuals to really make some decisions around how they can, be healthier. And as they build those relationships with our local harm reductionists and hopefully find their way to treatment, with the understanding that, not everybody is looking to be completely abstinent or 100% sober. And so this is a great approach to kind of let folks find what works for them. And so without further ado, we are going to hear from Carmela and Melinda at the Lancaster Harm Reduction Project.
What is harm reduction? Harm reduction is a range of public health policies designed to reduce the harmful consequences associated with various human behaviors, both legal and illegal. There are 6 principles of harm reduction. These are health and dignity, client-centered, client-involved, client self-rule, recognizes inequalities, and practical and actionable. I'm going to spend a few minutes going over these. Health and dignity is the way a provider respects, cares for, and dignifies a patient as an individual and looks at the whole person, taking into consideration quality of life on an individual and community level. This means providing care free of moral judgment. The client's well-being is the criteria for successful interventions or policies, not necessarily abstinence from said habit, addiction, or problem. Client Center focuses on a provider which should offer a range of supportive approaches that are practical, accessible, reasonable, and attainable for clients while allowing the client to lead the encounter and determine what their immediate needs are. A provider is a partner, facilitator, and advocate for this client in developing their wellness plan, appointments, or services. Abstinence from harmful behaviors is never prioritized or assumed to be the immediate goal of the client. Client involved. Every client presents with their own needs and strengths as well as behaviors. Clients also help identify both problems and solutions when participating in services, which is why it's so important for them to have a voice in the planning of programs and policies that serve them. This could be accomplished by inviting clients to be part of an organizational board, setting up task force or work groups, or even allowing them to participate in programs or service evaluations. Client self-rule. This recognizes that individuals will change when they are ready and when circumstances allow. Develop relationships with transparency where people are aware of the possible consequences to their actions. The goal is for the provider to provide the client with knowledge and information so they may have the opportunity to make an informed decision. Ultimately, clients will make their own choices about medications, treatments, and behaviors to the best of their abilities, beliefs, resources, and priorities. Recognizing inequalities. Providers must take into account the complexities of racism, class, poverty, isolation, past trauma, gender, sex-based discrimination, and any other inequality that makes one vulnerable and affects an individual's ability to deal with behaviors related to harm. As a provider, we must ask ourselves, how can we address these harms and minimize their impacts? Practical, actionable. Providers should offer practical tools and education to address the real harms and dangers experienced by clients with risky behaviors. Providers should be prepared to accept the situation as it is and to deal with it accordingly. Incrementalism is a major piece of harm reduction and refers to the idea that positive change demonstrated by the client is a step towards improved behavior and/or health, and that often positive behavioral health changes can take months or even years to achieve. Accountability without termination. This is when clients are seen as being responsible for their own choices and outcomes, but are never fired from care. A few examples of these are seatbelts and airbags, nicotine patches to help slow or stop smoking, sunscreen, suicide, domestic violence, child abuse, crisis hotlines, and even helmets and padding for sports. So why is a harm reduction approach important? Harm reduction values connection and compassion. It leaves space for those who aren't currently ready or willing or even able to stop a behavior to stay engaged and connected for the moment they are in. It recognizes that systems of oppression, stigma, and shame. It works. It really does. Research shows that harm reduction interventions reduce public health risks and act as a conduit to other services. And harm reduction keeps people alive. Really, this is the most important part. Harm reduction keeps people alive. It's cost effective and it creates healthier, safer communities. What harm reduction doesn't do is promote or enable harmful behaviors or protect individual clients from experiencing the consequences of the choices they make. Some harm reduction strategies to look into is language. Language matters. The use of our language in terms that are preferred to reduce institutional, societal, and individual stigma. Always make eye contact. An easy way to show you are engaged, present, and listening to the client. If you are relaxed and comfortable, your client is more likely to feel the same way. Avoid multitasking. This causes distraction. You are less likely to connect with the client and truly hear what they are saying. The person in the room is the most important and worth your time. Document together or after. Document notes after meeting or co-document so the client is being engaged in the process, building trust and transparency. Lastly, manage responses. Control your facial expressions. As providers, we all get surprised, frustrated, disappointed, or doubt what we have been told, but it is important to control our reaction. Motivational interviewing is a great tool. It's a counseling method that helps individuals resolve hesitant feelings and doubts to find the internal motivation needed to change their behavior. It is practical, empathetic process that takes into account how difficult it is to make life changes. Physical environment. This is a safe place, a safe space. Make sure meeting rooms is as open as possible, with easy access to door for comfort and safety for both yourself and your client. What do your posters or handouts say? Remember, language matters. Do they use outdated and stigmatizing language? Can your conversation be overheard? Are others walking in and out of your space? Are you sitting physically taller than the client or are you looking down at them? Are there screens or partitions between you? Eye-to-eye contact with maximum interaction is extremely important. And also comfy seating. Bright colors and privacy make a great setup. The less clinical feeling, the better. Harm reduction programs are evidence-based public health interventions to engage people who use drugs into addressing health and social risks. People who use drugs are more likely to enter drug treatment if they utilize harm reduction programs than those who do not. Actually, it's almost 5 times more likely. Participating in a harm reduction program does not lead to an increase in drug use. Let me say that one more time. Participating in a harm reduction program does not lead to an increase in drug use. A harm reduction approach provides that a conversation continues in spite of someone's drug use and works with an individual to make a plan to address their own health risks and social needs. So I want to talk a little bit about how our services have changed during COVID-19 in our community. Services are actually harder to access. If not, some of them are just completely closed. There's longer wait times, and services seem to be less personable. People are feeling isolated, alone, angry, frustrated, abandoned, unsupported, and hopeless. Suicide rates have increased, substance use is rising, and overdose rates have risen. Taking a harm reduction approach allows us to meet people where they are and provide resources and strategies to mitigate the harm they are experiencing on an individualized basis, especially during times of crisis, trauma, and uncertainty. If we have learned nothing else during COVID-19, may it be to start thinking outside the box and to, at a minimum, be open to new ideas and practices that uphold human rights and dignity while improving quality of life, if not saving it. Harm reduction saves lives with regard to substance use disorder. Naloxone access laws that ease restriction on naloxone possession and distribution are associated with 20% reduction in overdose deaths amongst African Americans. The Good Samaritan law provides immunity from prosecution for those calling emergency services, are associated with a broad reduction in overall overdose deaths, reducing overdose deaths by 13% overall. None of these harm reduction measures result in an increase in opioid or heroin use. These laws are effective at reducing overdose mortality without creating additional opioid use. Correspondingly, these measures should be considered an important part of the strategy used to address the opioid epidemic. You can find more information on substance use disorder or on harm reduction at www.drugpolicyfacts.org. Thank you.
Thank you both to Melinda and Carmela for putting that presentation together and sharing it with us. Carmela, you may, if those of you that know her, you know she was a little under the weather that day, but she powered through like a champ, and we appreciate her for that. You know, the thing that excites me about kind of the way that we've presented this today is that highlighting the principles that you do on a daily basis with folks really, I think, invites us all to an opportunity to kind of do some self-reflection and see how are we implementing those principles in the roles that we're in. You know, we have a variety of kind of experiences and skills represented here today, but I feel like there's always an opportunity, right, to put the client at the center and really think about you know, how we can meet folks where they are. I don't know if Melinda or Carmela, if you want to kind of briefly kind of tag on to that.
One more time, if you don't mind.
I was saying that I feel like focusing on the principles really allows folks an opportunity to kind of reflect on how they can take those principles and implement them. Even if they're not directly working with people who use substances, how can they apply that to just their roles? I think this is a great opportunity for like a little self-reflection moment, and didn't know if you wanted to share anything further about that.
When relating to anybody, it's basically you're looking at the individual, whatever circumstances they have going on, and you're giving them information, knowledge, and knowledge is power. So they can step by step incrementally decide what will help improve their life. And it's not going to be instantaneous. It'll be over time. And that's okay. a step, even no matter how small, is still a step forward.
Absolutely. Absolutely. One of the things I love about harm reduction. One day, one step at a time. So we have a question for Melinda and Carmela. What exactly are the harm reduction resources currently available to our Lancaster County residents?
Well, what we offer through our program is, of course, we're a syringe service program. So we offer clean supplies to people who inject drugs, as well as this year we offer safe smoking kits with COVID. We don't want anything being shared that can spread any disease. We offer fentanyl test strips. We offer wound care kits, hygiene kits. We have prescription lock boxes off and on.
Safe syringe containers.
Safe syringe containers, Narcan overdose kits. We have a plethora of supplies to help keep clients safe as well as the public. So syringes aren't being dropped in public spaces and putting people at risk, as well as, like I've already said, the spread of disease.
And for folks who maybe are a little less familiar with where and how you work, this work is largely still happening in Lancaster City, right? You want to say anything?
We currently operate in Lancaster City as well as York City and Harrisburg. We do have relationships that allow us to operate within the city limits, so we don't really go outside of the city. But you can find our information on Facebook, or you can call us. You can reach me at 717-808-1084, and we'll type that into the comments. And I can get brochures out to anybody interested or any organizations that may not have the information. And we're primarily word of mouth because we're mobile, and obviously it's a little contentious sometimes what we do. We're trying to normalize harm reduction, but again, it can still go either way.
Well, I am optimistic that we have maybe helped folks a little better understand, kind of the method, the reasons behind some of what you do today. I certainly hope that we have. A couple more questions for you folks. Have you found that fear of legal consequences locally prevents people from calling 911 in an overdose emergency?
Really depends. If it's like a drug house where there's a lot of people using, a lot of times, yes. Or they'll call 911 and the house will just go empty and they'll leave that person by themselves. Unfortunately, there is still the stigma. A good bit of people probably have warrants for one thing or another, and the fear of going to prison, especially when you're in active addiction and scared of the withdrawal effects, unfortunately still sometimes motivates people in the wrong direction. But then you have those that do have the Narcan, a lot of our clients who will stay with the person and hit them as many times with as many doses as they have and wait it out with the person. So it can go either way.
Okay, thanks. That's helpful feedback. Lori is wondering how she can put someone in touch with your services, i.e. fentanyl test strips. Is the best way to give you a phone call?
Yes, give me a phone call, and if you want some for your organization or to be able to distribute, we will help provide them to you.
That's fantastic. And that number again was 717-808-1084, and that is in the chat. And we'll make sure that we share that. Did I get it wrong? I see you ready to speak.
Oh, I was just going to say they can email me as well at mzip@lhrp.org.
Okay, we will share those again after the event for folks who are interested. We do have another question. Gail's wondering or commenting and then question, people are using drugs in many parts of Lancaster County and South Central Pennsylvania. Where else do you think you could take your mobile services? And she's wondering if joining forces could help you to expand.
Well, one of the areas we'll probably end up expanding to would be the Reading area at some point. No time frame on that currently. And then I believe we're kind of at a hold because of financial restrictions as of right now. Joining forces could help definitely spread the word and help us get outside of Lancaster County, possibly with working with all the healthcare systems they work with to spread the word and bring more knowledge to the issue. But we're hoping that the laws in Pennsylvania with regards to harm reduction change soon, which would allow us more freedom to go outside of the county and the areas that we're only allowed to operate in. So hopefully that'll change soon, and then we won't be so restricted.
Have you seen any legislation that's been introduced in Pennsylvania?
There is legislation that has been introduced, and I believe it's bipartisan right now. So we're hopeful, very hopeful.
That's encouraging for sure. So always, encouraging to hear when things have been introduced, but of course that can be a long, complicated process. So I would invite anybody who's interested in kind of learning more about that to be in touch with Melinda. Her information is in the chat box. Please keep your questions coming in. We are going to switch quickly to another poll. We'd like to get some feedback from you about harm reduction. Got to do my little tech wizardry here. So when you think about the principles that were highlighted in the presentation today, what is one principle that you feel like maybe you could really focus on implementing for kind of this second half of 2021? What is one thing that you can commit to kind of be more client-centered or client-focused and take a little bit more of a harm reduction approach? So again, if you've already logged into the Poll Everywhere poll, you're already in, and you can just submit your answer, A, B, C, D, or F. Health and dignity, client-centered, client-involved, client self-rule, recognize inequalities, practical and actionable. If Poll Everywhere is still just you're not feeling it today, we invite you to put those responses in the chat. So we are starting to get some responses. Looking like client-centered is something that folks are really connecting with and willing to make a commitment to for this year. Uh-oh. Shifting. And so for folks that have participated in the poll, and if you're thinking about kind of incorporating that client-centered principle more in your work for the rest of this year, if you wouldn't mind sharing, how are you going to do that? How are you going to do that in your role? How are you going to put clients at the center? Tell us a little bit more about that. Got a few responses coming in, but client-centered is still at the top. Great. I'm going to follow back up with everybody and see how that's going. Love to hear those stories about how that putting clients at the center may be changing your relationship with folks that you serve and their willingness or likelihood to engage in the services that you're providing. Okay, got another poll question for you. How many folks that are with us today have been trained in how to administer naloxone and currently have access to it? So certainly, naloxone is available through the Lancaster Harm Reduction Project. We also at Joining Forces have a grant that is available for folks who are looking to be trained in how to administer naloxone and how to distribute it to the folks that they serve. And so that grant is managed by my colleague, Deb Bard, and I've just put her email address in the chat. So for those of you who are responding no to this today, either you have not been trained or you don't currently have access, I would invite you to also be in touch with Deb to chat through about the training that she could offer to you or to your team if you are here representing an organization today, and how you may be able to get access to naloxone. Through that grant, we also have some partnerships with pharmacies throughout the county. And so on our website here at this link, you can find out a little bit more information about that, about where folks can go to access it. If they have, you know, a barrier of any kind to being able to pay for the naloxone at the pharmacy, for example, we have agreements with these particular pharmacies where folks can have it for free, and so they just need to let the pharmacy know that, and that is ongoing. Deb has also shared her phone number in the chat, so if you are more of a phone talker and less of an email, you can pick up the phone and call Deb at 717-544-3779. Okay. Any other questions about harm reduction or what our local friends at the Lancaster Harm Reduction Project are doing? The shelf life of naloxone. Lori's asking, what is the shelf life of naloxone? That's a great question, Lori. About a year-ish ago, there was an update to that, and so now the shelf life of naloxone is 36 months. So that's a great question. If you have some that has expired or is about to expire, that would certainly be another opportunity to connect with Deb to chat through that, how to safely dispose it, and how to get an in-date dose of naloxone. Good question, Lori. Thank you for that. Other questions? Yeah, Alice is sharing that as long as our Pennsylvania paraphernalia law exists, it will be difficult to advance needle exchanges. It will. And so certainly if this is an area that you as an individual are kind of interested in and passionate about, I'd invite you to learn more about it. There are some advocacy groups throughout the state and throughout the country who are working to make this more available. I'll also share that recently I've learned about the CDC really providing a lot of technical assistance around syringe service programming and really kind of touting the evidence behind it. There's been a lot of good that's come from it. Melinda or Carmela, do you want to add anything else that we may have forgotten before we move on with our next segment?
Remember to meet people where they are. Don't expect change overnight, and keeping them safe in the meanwhile and alive is the most important part of what we do. Right.
Absolutely. Thank you both again for preparing that for us and sharing all of those excellent tips with us. All right, so now we are going to move on to a new area that Joining Forces is exploring called Overdose Fatality Review. I'm going to share another presentation with you about that.
So we're going to spend a few minutes now kind of just talking a little bit about what overdose fatality review teams are, who makes them up, and how they work. So before we do that, let's just take a quick half step backwards and talk about why would we even consider this? Well, we know that all overdoses are preventable, and this reviewing these fatal overdoses is really a great opportunity to identify gaps in our system and specifically identify opportunities for enhanced prevention and intervention strategies. And we can take this information and design very specific strategies based on our local conditions. So it's kind of exciting. All right, so what does the team look like? What is the structure? Well, there is typically a lead agency that oversees the coordination and provides administrative support. There's a governing committee which supports and provides resources to implement the recommendations that are generated by the case review. There's the OFR team itself, which is a multidisciplinary team that reviews the series of individual deaths to identify system-level opportunities for prevention and intervention. And then once those recommendations are provided, there are subcommittees that are created to really implement those strategies at the local level. So who makes up the team? Well, it's a variety of stakeholders, including law enforcement, public health, EMS, the coroner's office, probation and parole, behavioral health social workers, school counselors, representatives from the housing sector, the prosecutor's office, addiction treatment professionals, addiction prevention professionals, harm reductionists, representatives from drug treatment court or family treatment court, faith-based leaders, and of course representatives from the recovery community. Every new team member will participate in an orientation which includes trainings around overdose fatality review teams themselves, opportunity to review the addiction as a disease model, the social determinants of health, and how our language can reduce negative attitudes and beliefs about people who use drugs. So ahead of each meeting, the facilitator, who is typically part of that lead agency, will pull the cases for selection. Now, the team itself will identify what that criteria is that makes it an appropriate case to review, but then it's the facilitator who's identifying we're going to review this particular case. And then the facilitator will gather specific information about that case, requesting it from the team members, and prepare a summary of the case that will go out to the group ahead of the meeting. And then each participant, each team member that plans to attend that meeting will review the case. They'll prepare a summary kind of from the lens of their interaction with that individual. Some overdose fatality review teams have agencies fill out a very specific form. We want you to answer this piece, and this piece, and they'll prepare any additional updates from their organization, making sure that they have a representative to attend that meeting. And of course, we encourage them to take notes. So all of this happens at the meeting under these guiding principles, that there is a shared goal from all team members to reduce overdose deaths. Again, that all overdose deaths are preventable, that substance use disorder is a chronic treatable illness, using multi-sector data to inform all the strategies, and continually improve the OFR process and the local prevention activities. So this is a sample of what a typical meeting agenda would look like, reviewing the ground rules and the goals of the group. At every meeting, there is a confidentiality agreement that is signed by each member. The facilitator will present the case. Each team member will have an opportunity to share additional information about the case. The entire case is then re-summarized, a timeline is created. That's all used to formulate recommendations. Everything is summarized, next steps are identified, and the meeting is adjourned. So that's the typical flow of a meeting. The case presentation is typically a lot of basic demographic information about the decedent, where the overdose happened, when it happened, any information that can be gleaned from the obituary or any pertinent news coverage or social media coverage is included, along with, when appropriate, information gathered during interview of family members. This is a sample timeline that is created through the case review, and this information just really helps to provide a great visual cue for the team to help kind of identify some of those gaps and missed opportunities and formulate their recommendations. And so then the facilitator kind of takes all that summary and that timeline and walks the team through a problem-solving process by asking some of these questions. What are the missed opportunities in this case? What are the system's gaps? What can be done to improve service delivery or intervention? And how could this be implemented and in what settings? So the group will discuss all of those as part of how they formulate their recommendations. And again, the recommendations are really designed to improve service delivery and investigation. It's an opportunity to review agency policies and procedures, to revise local ordinances or even state legislation, and to really initiate or modify our local prevention strategies. So of course, as I kind of alluded to earlier, this is an incredibly data-driven process, and so there is an entity that must be responsible for collecting and storing all this information. There are standard data elements that are gathered from all team members, and there is a template to refer to that is available for any team looking to get started to use. Some of the data collection elements include, of course, all of the meeting details themselves. All of the confidential information that's shared is stored in that secured database. All of the case information about the decedent, their demographics, any death scene investigation, any interventions that happened following the overdose, their history of life circumstances and stressors before the incident, any local conditions that may have been a factor in the fatal overdose, and then of course all the recommendations that the team identifies at the end of that meeting. Everything is kept in that secure database. And so of course we're sharing a lot of confidential information, so confidentiality is essential. All team members will enter into data sharing agreements, and every participant will sign a new confidentiality agreement at every meeting. Again, just really reminding the importance of what happens in the room stays in the room. And then that information can also inform any state legislation. So we have an example from Maryland, and this was really the first team that started in the United States, first overdose fatality review team. And they reviewed about 416 cases, and what they found in a period of about 18 months was that of those cases, a significant portion had mental health comorbidity. They also had chronic health conditions. They had a previous non-fatal overdose. That was reported in about a quarter of the cases, and similarly, about a quarter of those cases, also of those individuals, were engaged in pain management. In about 18% of the cases, there was a history of suicide attempt or suicidal ideation. Many of the deaths had occurred at hotels or motels, and this was a large population of folks experiencing homelessness. So there was they were alone and there was no one there to provide that timely aid. And then they also noticed a trend in individuals who had acquired brain injuries. So taking all of those trends, they were able then as a team to identify some recommendations. So of course they did some preventative education, really just kind of raising the general community awareness about kind of the local overdose epidemic that they were experiencing. But they also did some very targeted education to specific providers, physicians, businesses like those hotels and motels, for example. They explored opportunities to integrate care, so incorporating screenings for substance use disorder into health services and medical settings. They put peer support providers in the emergency departments, and they put into place protocols for follow-up to make sure that any referrals provided were that folks made those contacts. It also led to the increase of providers using their prescription drug monitoring program. which was kind of cool. And then it really allowed for enhanced care coordination of those individuals. They looked at local harm reduction strategies, so they were able to update their Good Samaritan laws and increase access to naloxone, and of course the training that's necessary to administer naloxone. They really targeted their efforts to people who use drugs and their loved ones, knowing that they were more likely to witness an overdose and be able to respond to it. They provided naloxone training upon discharge from substance use disorder treatment, and of course to a lot of those hotel and motel owners, managers, staff. They did some things to enhance existing services. So they were able to make trauma counseling more accessible. They were engaging treatment providers in overdose prevention, providing access to services during non-traditional hours, treatment for couples and partners to be able to attend together, and increase the capacity of treatment providers to be able to test for fentanyl. They were also able to really do a lot of increased information sharing, so better communication among agencies. Emergency rooms started notifying drug courts if there was an incident. And then there was a need in this particular community to standardize how folks accessed shelters. And so they were able to do some standardization there as well. And all of this was gleaned from those case reviews and those trends that they had identified. So you can see that the recommendations that can come out of these teams can be incredibly varied, and it's all based on kind of that local context and local conditions. And so that is what overdose fatality review teams are, and a little bit about the process. And so now we'd like to hear what you think. We have a couple questions for you. Okay, so we are back to our trusty old poll, wondering if you feel that based on the information shared would be a valuable asset to Lancaster County if we were to create an overdose fatality review team. So again, if you have already registered to participate in the poll, you're in and you can simply share your response. If you have not registered yet, you can start a new text and send a message to 37607, and in the body you'd type JForces 891 and send that. Message and data rates do apply, and then you'd be able to kind of be involved in the poll that way, or again through the website. And of course, the chat box is an option for anyone who is having technical issues, as I think we are behind the scenes today. Hopefully it hasn't been too disruptive for your experience. So far, it looks like 100% of folks that have participated in our poll feel that creating an overdose fatality review team locally would be a valuable asset for Lancaster County. So that's pretty unanimous. Okay, and so if we were able to create this team, or if you would be interested in kind of helping us learn how to make this happen, if you could indicate that through the poll. On our post-event evaluation today, we will be inviting you to kind of share your interest there as well, and asking you to let us know how we can get in touch with you. So
there will be a follow-up evaluation that you will receive via email later today. We would greatly appreciate your feedback on that. Okay, so seems like we have some folks who are also interested in learning more and or possibly being one of those team members. So that is encouraging, very encouraging. If there are any questions about the Overdose Fatality Review Team, about the process or any other particulars that we may be able to answer, I'd invite you to put those in the chat box at this time, and I'll do my best to answer those. And if there are any other lingering questions that you may have about the data or about local harm reductionists, we would invite you to put those in the chat now as well. Okay. Well, Alice, this may be the only time in history that we are running a little bit ahead of schedule.
Awesome. Can you hear me, Chris?
Yes, we do have a question from Lori who's asking when the teams actually meet, if they meet during the daytime or in the evening. So, Lori, I think that really depends on when the team members are available and what's convenient. So that would be something that would be identified. And kind of the makeup of the team may be a little bit different depending upon the particular case that's being reviewed. That is a good question. I know that you're passionate about these issues, but you do have a full-time day job, and so it can be tricky for you to be able to participate today. So that is definitely a good question and something for us to consider. And then we have a question from Gail. Strongly support Overdose review to get more information on where we could better intervene with services to help save lives. But have we done research in Lancaster County with people who use drugs? Ethnographic research, interviews, or surveys, because we could probably learn more from them about how they've been involved or not with our systems by asking them. And that would be less complicated and faster than the process of setting up the overdose review. So, Gail, I personally am not aware of any formal research that's been done. I believe that there are a variety of community partners who do outreach with people who are still actively using substances, and I do think that they engage in those formal conversations. I think that would certainly be an opportunity for us to be better at sharing that information with all of the stakeholders and really looking at how that could be used in a more systematic way. I don't know if anybody else has anything to add to that, maybe that I'm not aware of. Brenda, are you aware of any research locally that's been done with people who use drugs?
I am not. I am not typing fast enough to be able to respond here, but yes, I would say the same thing. Not aware of any formal research. What we do when we want to know, hey, what's happening with something is we ask harm reduction folks, the people in the Recovery Alliance. So I think a lot of that is done, informally and regularly, but not in an organized way.
We'd be willing to help, but it would have to be a very structured, short survey because they don't want to take a whole lot of time usually to do long surveys. So,
well, we do have an opportunity with the community health needs assessment happens every 3 years in Lancaster County. The nonprofit hospitals work together on that, and we're planning the plan right now for how we're going to collect data for the needs assessment. And I have grand ideas about work that I want to do to collect information from different groups of people who are at risk for health issues in the county. And so I think that would be great if we can try to work that into the community health needs assessment and make it really what do we really need to know? Because I have no doubt that Melinda would be able to get the answers from people who can really tell us. So that's great.
Yes, for those folks that are less familiar with the Harm Reduction Project, Melinda has a small but mighty team who are really doing some wonderful things, and I do think that they have the right kinds of relationships with folks to really get some great feedback that we can trust. So, Melinda, we appreciate your offer, and we'll make sure that we stay in touch on that. Any other questions or thoughts about data, harm reduction, overdose fatality review? Gail likes your idea, Brenda, of making that part of the community needs assessment. Are folks with lived experience or people who use drugs a part of the death review data team? They certainly could be, Carla. Of course, we want to make sure that we're not unintentionally causing harm. We would want to invite people with lived experience to participate, but we want to make sure that it wouldn't be more harmful for them to participate than the valuable feedback that they would provide. So we would certainly explore that. But I am personally a fan of nothing about us without us. So I do believe that is an important perspective to include in those. Gail is sharing an upcoming webinar about harm reduction services. So for folks who are looking to learn a little bit more about reducing harm and building public health equity, Gail has shared a link in the chat box to that and is encouraging you to share that with other folks who maybe are not able to be with us this morning. So thank you for that, Gail. That looks like a great resource, and that's happening next week, and it is a webinar. Other questions before I turn things over to Alice? Looks like Alice has lost me. I don't know if...
I'm here. Can you hear me?
I can hear you.
Can you see me?
I do not see you. It looks like your video is off.
How about now? No?
There you are.
Okay. All right. Thank you, Chris. Okay. Hi, everyone. First and foremost, I want to say, give a big shout out and thank you to Chris and Christina for just getting all the detailed pieces to make the webinar possible. Did an absolute great job. You talk about some glitches, but we're all sitting here imagining if we did that, what things would be like. So thank you so much for doing all of that. And thank you to Commissioner Parsons for kicking us off and helping to move things forward on the almost month by month, week by week as issues come up related to the Joining Forces Steering Committee and moving things forward in whatever his purview would be to help with that activity. So thank you so much for that, Commissioner Parsons. And then Melinda and Carmela, thank you for your presentation. It was wonderful. I'm sure you were a little relieved taping it ahead of time and then being available for questions. You did a great job, so thank you for that. And thank you for everyone participating. I'm just going to wrap up with a few comments and next steps as we see it as it relates to the Joining Forces Steering Committee and how we're thinking about moving forward. So some of the obvious things that came up is support related to looking into the opioid review fatality team, opioid fatality review team. And so we are actively working and discussing things with the state to see how this could be done. It's the one thing that didn't come up as much that I'd like to just reinforce is that, as Chris mentioned, in terms of the sensitivity of the information that would be shared, I think a big piece to that are the confidentiality elements to all this. So I had been on the initial team for the child death review team that's currently in Lancaster County, and you have to really sign off from a confidentiality standpoint. The information that you have at your access is very private, but it does help figure out if there are trends, in that case related to any child death, that could be actionable to prevent another child death. And we're looking at the same thing here, but there seems to be certainly more sensitivity around that. So we need to be really clear as we're talking about it, that the people that are on the team, it's a very confidential process and information that's shared in order to get to the next level of information. So even before the pandemic hit, I think there were a lot of you in our last in-person forum that we had, particularly during the breaks. We talk about, we're always trying to figure out with all of you, not only during these forums, but in between, about what are we seeing and why is it happening and what do we need to do more of, or actually things we need to do that are new and different, innovative, evidence-based, when at all possible. And we do feel that the opioid fatality review process will help us get to that next layer, even pre-pandemic and now. So we're excited about moving forward with that. And as Chris mentioned, when the evaluation comes out, there will be an opportunity to let us know if you're interested in exploring that more. And that would be very much on a good portion. Some portion of that would be pretty quantitative, more than we have now. But their qualitative piece that everyone was asking for about, asking people nothing for us, without us, would certainly be a joint part of that, whether they're part of the team or whether it's more deeper dive informational piece with getting feedback. So that's number one. So that's a big push of what we're doing from a joining forces standpoint to see how we could add value to the good work that's already being done by lots of organizations and all of you on this forum for today. The other thing is around overdoses and the increase that we've seen during the pandemic. I think we mentioned at the last forum too that there's been a lot more collaboration between the Let's Talk Coalition that's focused on mental health and mental well-being and the work of joining forces because of co-occurring and knowing that sometimes these are not in isolation, so we need to work together. So a big focus on thinking about the increased amount of anxiety, depression, stress that we all have had to some extent during the pandemic, and what are some things that need to move into action in order to get us on the other side of all of that. And I would say with the groups that I've been involved with, particularly since the pandemic started, a lot of you that are on this forum for today and those that were not able to make it really looked at innovative ways to keep as much of your connection with folks that are in recovery and ways to do outreach during pandemic time. So there was amazing work being done then, but now we're getting on the other side of the pandemic that we need to kind of rev up those activities and then again also think about anything new or different. And that aligns well with the trauma-informed work that we're doing jointly with Let's Talk. So we have three main different goals that maybe might not be so different, but more intense and more focused in terms of the work that the steering committee, in particular with all of our partners, push forward, and that is the opioid fatality review team, and it also is the trauma-informed care is the second one. So it's really aligns well with that type of activity. And then the third, another observation that I had was we talked about this a little bit at this last steering committee for joining forces about the increase in prescription opioids during the pandemic time. So we do have another partner in the work that's being done that's mainly the healthcare provider side of overdoses and substance use disorder, and that's the South Central Pennsylvania Opioid Awareness Coalition. And I believe Rosemary Search is on this call, and she would be working with those providers, which include all the health systems, FQHCs in the South Central area, and they're the ones that actually worked really collaboratively to share best practices to implement to reduce the amount of opioids that are used on the medical side and then ultimately making them sort of less available if they go into the general public. So that would be something that group will be discussing and coming up with solutions or understanding perhaps what the linkages are of what the data is telling us and the work of the providers and what can be done differently moving forward. So that observation of the data, just know that that's being handled with a coalition that exists already, and we don't need to form something different because that's what's good about having partners. And then related to the harm reduction work, as Chris mentioned, the next step on that will be in the evaluation. If you're interested in advocacy work around that, we'll look to see who's already doing that in the community and how we can link you to that. Or if more work needs to be done, then we can look at maybe thinking about how to enhance that organization of that type of work. But we know that a lot of that work is already being done and maybe just need to coalesce a few more partners. Which brings me to the last point, which, as we said from the beginning, this work cannot be done alone by any one partner to make, or any one organization to make a significant impact in reducing deaths from opioids and heroin. So that it's all the partners that are here implementing evidence-based practices when at all possible and or evidence-informed. So start, taking things to scale if we don't have enough of it, because there's a lot of work. How do we look to try to do that? So really grateful for all the partners. And with that being said, too, I just mentioned the three main areas that Joining Forces is looking at advancing in the coming year. But the other interventions that we had, when hopefully you all know about the SAMHSA wheel, where we're looking at primary prevention, first and foremost, how do we prevent substance use disorder, all the way to recovery, and then creating a community that is recovery oriented and supports people that are in recovery. So that whole continuum and all the work that's being done by the partners on this call and others is still very, very important to the number and the data that Brenda shared with us. So we got to keep that going. So thank you all for participating and being part of this. Keep your questions, thoughts coming. Chris is setting up a way with the post-evaluation to be able to make that all happen. And my last push is we're hoping the next forum we can have in person, but we need more people to get vaccinated. So really encourage all of you, if in doubt, feel free to contact me individually to have discussions about the safety of the vaccine. Certainly available. Anyone 16 or older can get the vaccine. Encourage you to go to vaccinatelancaster.org to learn more about where to get the vaccine in our community, certainly at the Community Vaccination Center. So thank you all for joining today, and have a good rest of week. Bye-bye.